Okay, good morning, students. I'm going to spend the next few minutes speaking about arbovirus infections, and the ones that we are speaking about today are primarily dengue, chikungunya, and Zika. I'll try and get through this in the next um, half an hour to 40 minutes. Thank you so much. So this is the Penta Foundation with our Jamaican colleagues who are interested in this topic. And so the arthropod-borne viruses or the arboviruses, these are transmitted primarily through the bites of infected mosquitoes. And these have started out mainly because of the global dengue epidemics, which have been around since the 1800s. And since then, they have had global spread of the Aedes aegypti right across the world. And remember, this is a mosquito that lives in the subtropical areas of the world. So wherever there is a subtropical climate, this is where the organism and these three viruses will live. Global spread has contributed to its spread around the world. This started first with the slave trade, and then we moved to urbanization, increased population growth, climate change, global warming, and also transportation. Dengue is now a risk to over half of the world's population. We have over 100 million severe cases each year, and roughly 1 in every 2,000 dengue cases result in death. Children have the most severe presentations and the highest attributable morbidity and mortality. And CHIKV, as we know, we had an epidemic in 2014, and Zika, we had an epidemic in 2016 in Latin America and the Caribbean. Now, these viruses are classified as flaviviruses, that is Zika and dengue, which are both cross-reactive, and Zika is neurotropic. There are 4 dengue serotypes and 2 Zika lineages, the African lineage and the Asian lineage, which had been circulating in the Caribbean. Chikungunya, on the other hand, is a toga virus. The mosquitoes and the vector are spread. The vector is the Aedes aegypti and the Aedes albopictus mosquito, and they are both aggressive daytime biting mosquitoes. It can also be spread by mother to child through blood, sexual transmission, saliva, tears, lab accidents, organ and tissue transplants, fertility management, breast milk, and nosocomial spread. These viruses may circulate together, that's Zika, dengue, and chikungunya, and they may become endemic or hyperendemic. We're gonna speak to it as it relates to mother to child transmission and spread from the bite of the mosquito. Now, the Zika, let's start with Zika. Zika was first identified in the Zika forest in 1948, and then in 1947, and then it spread into other African countries, and from there to Pakistan, and then from there to Malaysia, Indonesia, the Yap Islands, French Polynesia, and expansion into the Americas in 2015. In 2015, you'll remember there was a public health emergency of international significance declared as a result of the Zika outbreak and its effects in Latin America and also here in the Caribbean. This virus is present in the dengue belt, and the dengue belt is shown here in brown, where essentially this is where the dengue virus transmission occurs. And this is the same parts of the world where you have risks of, excuse me, somebody burning, excuse me, of CHIKV and ZIKV transmission, because this is where the Aedes aegypti mosquito lives. Excuse me for sneezing, I'm sorry. This is the epidemic where it had been affected, at the height of the outbreak. There were 84 countries with mosquito-borne Zika transmission, 61 with a reported outbreak, and from 2015 onwards, at 47 of these countries were in the Americas, including Latin America and the Caribbean. Attack rate for ZIKV is very high in island populations. So we had a 66% spread in French Polynesia and a 73% spread in the Yap Islands. Explosive spread is influenced by the fact that the population is non-immune, there's a high population density, it's a tropical climate, and inadequate control of the Aedes aegypti mosquito. And then here we are with a chart as it relates to the Arbovirus cases in Jamaica from 1986 through to 2016. You will see in blue that we have had dengue outbreaks since 1986 going right through, well, to 2018. 2018 is not shown here, and 2019. And this is shown in blue. And then you will see that since 2007 until now, we're having increasing intensity and increasing reported cases of dengue, which is in blue. And then in 2014, we had a Zika outbreak here in Jamaica, and that is shown, not Zika, chikungunya outbreak as shown in orange. And that outbreak was pretty significant. And then in 2016, we had a Zika outbreak with over 6,700 cases reported. This was also occurring on the background of dengue, as you'll see, with over 2,000 cases reported. And chikungunya was also being reported as well, to almost 400 confirmed cases reported. This is the epidemiological curve for Zika, and you'll see in red the confirmed cases. I think we had over 204 PCR confirmed cases. And then the suspect cases peaked and notified cases peaked in the middle of July 2016, and the epidemic tapered off thereafter. The clinical features of these viruses, they all present in the same way. They present with fever, rash, and joint pains, and headache and myalgia, as you can see here. Zika presents primarily with rash, but it also presents with fever, conjunctivitis, and arthralgia. Dengue presents primarily with fever. In fact, they call it breakbone fever, but it also presents with myalgia, headache, and hemorrhage, while chikungunya will present with fever and arthralgia. Dengue fever, we know, is a severe, undifferentiated febrile illness in the young, who will present with headache, pain behind the eyes, muscle and joint pains, nausea, vomiting, swollen glands, rash, and high fever. Non-severe dengue of itself is a biphasic illness without warning signs or with warning signs, and these warning signs will include severe abdominal pain, persistent vomiting, rapid breathing, bleeding gums, fatigue, restlessness, and blood in the vomit. Severe dengue, on the other hand, will present with plasma leakage, fluid retention, severe bleeding, with severe multi-organ impairment. So you have dengue hemorrhagic fever and dengue shock syndrome. And if you don't do anything for the kids who present with severe dengue, they will die without supportive intervention. The warning signs are again noted here, and I just went through them, but they're abdominal pain and tenderness, vomiting, clinical fluid accumulation, mucosal bleed, lethargy, restlessness, liver enlargement, and laboratory evidence of an increased hematocrit with rapid decrease in the platelet count. The criteria for severe dengue are shown here. You have severe plasma leakage leading to shock and fluid accumulation with respiratory distress. Severe bleeding will be evidenced as evaluated by the clinician, and severe organ involvement can be shown with abnormality in the liver enzymes and so on. When this is very, very high, the patients will have impaired consciousness and will have cardiac and other organ involvement. Newborns and infants will also present with severe dengue. They have mild or moderate clinical manifestations, or they may even present with severe disease. These will go on to include upper respiratory tract manifestations, diarrhea or seizures. They'll have plasma leakage into the intravascular space. They have hydroelectric disorders and hepatosplenomegaly. They will also present with shock, which evidences with hypothermia, restlessness, lethargy, cold extremities, and tachycardia. Vertical transmission of dengue is evidenced in the younger ones, like the newborns, whose moms may have dengue. These babies may be asymptomatic or they may be symptomatic, presenting with fever, rash, thrombocytopenia, and hepatomegaly. They may have an uncomplicated course or they may have a severe course which resembles sepsis, as shown here. Some of the children may have underlying disease or they may have conditions which require them to use non-steroidal anti-inflammatory drugs, and these children need to have very close monitoring because they will be at risk for bleeding. The clinical presentation, 75% of all dengue infections are asymptomatic, and symptomatic infections will present with mild or moderate acute febrile illness, and 5% will present with severe life-threatening disease. Sorry. The clinical case follows 3 phases: febrile, critical, and convalescent. In the febrile phase, you can see here where dengue is present with a very, very high fever, accompanied by 2 of the following signs. Infants and young children will have fever, runny nose, rash, and diarrhea. The older children will present with the classic breakbone fever, with body aches, backache, and arthralgia. Symptoms will last for 2 to 7 days after an incubation period of 4 to 10 days after they have the bite of the infected mosquito. The critical phase will begin at defervescence and it lasts about 24 to 48 hours. Most patients will clinically improve, but some will have significant plasma leakage, which can result in severe dengue, and this can cause death if there isn't proper medical care. And then you have the convalescent or recovery phase, which lasts about 72 hours. And what happens now is that the plasma that leaked out starts to be reabsorbed into the body. And now this is the phase when you have pleural or abdominal effusions. Sorry. You have hemodynamic instability, and the patient will diurese, the hematocrit will stabilize or fall, and the white cell will rise. At this time, some patients may have a rash called the white isles on a Red Sea, accompanied by generalized itching. There's also the risk of hypervolemia. These are some of the historical findings that you need to look out for when you're taking the history, not only fever, but how much fluid they're taking, assessment of the warning signs, assessment of gastrointestinal involvement, change in the mental status, and change in the urine output, and also get a history of possible exposure of relatives with dengue or persons within the neighborhood or school with dengue. The physical exam, you need to pay attention to the vital signs, status of hydration, and the hemodynamic status. As shown, assess the mental status, look for pleural effusions and tachypnea and how the patient is breathing. Check for abdominal pain, ascites, and hepatomegaly. Look for the rashes, and check for bleeding or a tendency towards bleeding. Some of the investigations you'll do include the complete blood count, as shown here. Um, and again, remember we spoke about the hematocrit. It can be, you can show hemoconcentration. You can have a decreased white blood cell count or an increased white blood cell count. And you can have thrombocytopenia as well. We also do the NS1 antigen and the IgM IgG, but I think the NS1 antigen is more what we do here by the private doctors will do. The private labs will give you that test result. We also look at liver function tests, blood glucose, serum electrolytes, cardiac enzymes, and so on. So in 2012, we had an outbreak of dengue in children here in Jamaica. And we had, at the University Hospital, we had 134 children who were hospitalized with dengue. 88% of them had a confirmatory dengue test, 90% of them were uncomplicated. Severe dengue was found to have a longer duration between disease onset and hospital admission, and comorbidities of sickle cell disease and asthma were prevalent. Short stature was found to be predictive of severe dengue, maybe representative of early malnutrition of patients who lived in settings that were probably from representative of the lower socioeconomic status, where the children would have been malnourished, and so they were shorter than their peers. And in that study, we had 3.73% of those children died. You can see here the children presented with vomiting, rash, headache, abdominal pain, petechial ecchymosis, eye pain, arthralgia, diarrhea, and hematemesis as the prominent signs and symptoms. And then we had a chikungunya fever outbreak in Jamaica. We all remember what happened in 2014, summer of 2014, when the virus came to Jamaica. Most households were affected by the illness. There was widespread absenteeism from school and work, loss of productivity, economic losses totaling over 60 billion at the height of the epidemic. There was a major impact to the health sector, with increased numbers seen in clinics and in the emergency departments, and increased need for bed space and pharmaceuticals and diagnostics. And in the 200 children who were seen in 2 hospitals, meaning University and Bustamante Hospital for Children, you'll see the epidemic curves showing the number of cases for the summer of 2014 compared to the summer of 2013. And you'll see the excess number of cases at Bustamante Hospital for Children in hundreds, and the excess for fever and the excess pediatric cases at the University Hospital in tens. So among the 200 children, 93% of them reported household contacts. 99% of the children had fever with a median of 102.4. They had maculopapular rashes and joint pains. Infants presented at less than 6 months with irritability and groaning. There was also kids who presented at 6 months to 6 years with febrile seizures, and then there was CNS involvement in up to 24% of cases. Here we have some of the pictures of the children who presented. You'll see the babies with maculopapular rashes, and around the buttock, you can see here, almost looking like a staphylococcus scalded skin syndrome. You will have here the joints that were involved. Here you have another joint that is involved. So the rash would come up as a red maculopapular rash, as you can see here in this baby. And then as time goes by, it can come up as a blister, as shown here. and then later on it heals with brawny desquamation, as shown here or as shown here in this baby's neck. In an older child, you'll see here that they present with the same blistery rash and or maculopapular rash, which heals with desquamation. Here we have ZICV. ZICV also presents in the same with, with fever and rash, as I said before. And this person had an itchy rash. They have itchy rashes, as you can see here, and the rash involves the palms and the soles, as shown here. Yeah. They also have headache, and they also have conjunctival hyperemia, and arthralgia, decreased appetite, and malaise. Here we have the complications of Zika in the first reports from Brazil, when they had an unusual increase of newborns presenting with microcephaly. As you can see here, this baby's face looks large, but it's not that the baby's face is large, it's that the skull and the brain within the skull is small. So it makes the ears look large and the face look large. Okay, so microcephaly, um, it was confirmed that Zika was indeed causing microcephaly or a small brain, and this was proven using the Shepard's criteria and the Bradford Hills criteria for proof of human teratogenicity. And essentially, this it was shown that exposure to Zika did indeed occur during a critical time of fetal development. So this would have been shown in persons who would have traveled to the Caribbean or Latin America, say from Iceland, pregnant, and they got pregnant while they were here during the first trimester. And then when they go back to Iceland, where there are no mosquitoes, they would deliver a baby that has the Zika congenital syndrome. Subsequently, they have found that clinical cases did indeed fit the clinical syndrome, and rare exposures have also led to this rare outcome. It has been shown that patients have severe microcephaly with intracranial calcifications and other brain anomalies. They have cataracts and microphthalmia, they have hearing loss. They also have quite a bit of redundant scalp skin. Why? Because the severe microcephaly causes overlapping cranial sutures and a prominent occiput and the redundant scalp skin. So what happens is that the scalp continues to grow as the brain itself um, shrinks, and therefore you have this heaped up scalp that is there as well too. They also have abnormal amniotic fluid volume and intrauterine growth retardation. And here you have, this is more clearly shown. You have this baby here whose face again looks very large, ears look very large, but really what has happened is that the brain is very small and has collapsed. And here you have the collapse of the scalp, the occipital bones. You can see that the occipital bones are collapsed, and the scalp skin is heaped up. You can see the heaped up scalp skin here. So the scalp continues growing, but the brain doesn't grow. And then the overlapping skull bones you can see here. So it gives you a prominent occiput because the parietal bones overlap each other and slide below the occipital bone. And same thing you have here. The frontal bone is, so you have that, okay? Here you have the contractures and then and talipes equinovirus and the arthrogryposis. You can see how the joints and fingers, you see that? Yeah, and it's very, very clear, arthrogryposis, okay? So we also found that Zika congenital syndrome, the babies can be born with a normal head circumference and look quite normal, and then later on they actually die. This little young man was on TV recently. He was about 6 years old. He would have been born in 2014, so 6 years old would put him to 2020, yeah. And he just died, he just died. And essentially the news picked it up, and I remember seeing him on, is it N- NCB or ABC TV? I'm not quite sure. But he's really lived a short life, but did a lot to educate us on this illness. And we have our own cases too. Here we have a child with microcephaly, congenital microcephaly. And again, this is one of our babies. You can see the face looks large, but it's not that the face is large. It's because this the brain is small and collapsed. So therefore the ears looks big and the brain is collapsed. Baby has a lot of hair, so you're not seeing it as well. This baby also has significant eye signs, and you'll see the baby has significant arthrogryposis. See? There's also the rocker bottom feet. You'll see the overlapping scalp bones, prominent occiput, cortical atrophy, absent corpus callosum, and there's a huge proencephalic cyst here. So here in Jamaica, at that time, they had over 10,000 notifications, of which over 7,000 were suspect and 203 were lab confirmed. There were 827 cases reported in pregnancy, of which 698 were suspect and 78 were lab confirmed. And for microcephaly reports, there were 170 reports, of which 50 were confirmed, 35 were non-severe, 11 were severe, 4 were related to arthrogryposis, and all the babies were living with their mummies. Here you have another case. This mother had fever, rash, and joint pain in the first month of pregnancy, and she had no antenatal care. The baby had microcephaly with ventricular megaly and calcifications in the thalami and basal ganglia and in the right frontal lobe with a huge posterior fossa cyst. There was also severe arthrogryposis, right lung hypoplasia, cryptorchidism, chordee, gastric GE GERD, right inguinal hernia, and there was also the baby died, and the autopsy confirmed all these features. Zika also was causing Guillain-Barré syndrome at the height of the epidemic. You'll see here that this represents the suspect Guillain-Barré cases. The green represents the notified Guillain-Barré cases, and the blue represents the suspect Zika cases, and the orange represent the confirmed Zika cases. So Guillain-Barré syndrome cases increased in tandem with the outbreak here in Jamaica. We also were seeing neurological syndromes in adolescents, and you will see here that there were 5 adolescents who present with paralysis and acute neuroinflammation, 3 with acute myelitis, 1 with acute disseminated encephalomyelitis, and 1 with Guillain-Barré syndrome. All had close household exposures to Zika. Diagnostic tests were being done. Oh dear. skip that. So let's skip now and speak very quickly now about treatment of these conditions. The home treatment for dengue, we need to ensure that patients are taking fluids and they're passing fluids at least once every 6 hours in the last 24 hours. They should have no associated clinical underlying diseases or should be have any social issues that would put them at risk for poor outcomes. They can be evaluated daily, either by phone or they can come into the emergency room or to the clinic to be evaluated. So you can look at the evolution of the disease as an outpatient. When the fever subsides, you can check for the clinical warning signs. Patients and caregivers are to return immediately to the nearest healthcare facility if there are any warning signs develop. Fever is controlled with acetaminophen. Comorbidities, remember, should look out for those who are on NSAIDs because if so, we need to discontinue those and look for patients who are on other who have comorbidities that will make them at risk for poor outcomes with dengue. So for if they're on antihypertensives, we need to stop them because when the blood pressure falls, then this patient may go into shock in a more regularly. Dengue with warning signs, patients with plasma leakage should be admitted to hospital and given IV fluids, preferably Ringer's lactate or normal saline. Then they're evaluated looking at their urine output and input output chart, and you monitor the fluids accordingly. Look at their trends in the hematocrit. Those with circulatory compromise or shock should receive rapid volume replacement, give 3 boluses until they're stable, give oxygen and crystalloids or blood as needed, and reevaluate over every 6 hours or so for 48 hours. And some patients may even need fresh frozen plasma. So we need to pay attention to how we manage them. Looking at these 3 diseases, we usually give supportive care for all of them because we have no known antivirals that will cure this illness for these patients. Non-steroidal anti-inflammatory drugs are contraindicated. For dengue, as shown, we give fluids, electrolytes, oxygen, blood, and fresh frozen plasma transfusions, and multi-organ system support as needed. For chikungunya, we give rest, fluids, analgesia, antipyretics, drugs for tenosynovitis, arthritis, and psychosocial support long-term for the complications. And Zika, it's mainly psychosocial support with multidisciplinary management. We also give IVIGG and prednisone for immune-mediated complications. And then we prevent these by giving vaccines. There are many vaccines out there, but we're not using them right now. They're still being developed because there are many different concerns associated. And we practice mosquito avoidance behaviors. We know that the mosquitoes are out now. They're everywhere. So we do the best that we can to control them. And finally, this is another team that's working on Zika action with our Jamaican colleagues with persons here from all over the world. So thank you. At this point, I'll take any questions. Are there any questions from anybody? Hello? Any questions from
No, Doc,
anybody?
no thanks.
No questions. All right. So the slides are available online, yes? And the talk is available online. Okay. Thank you so much. Have a good evening now.
Thanks so much, Doc.